We're still sheltering in place, so we're going to keep answering your questions about COVID-19. That's the topic of this week's Healthcare Triage. Question 1. Do you think people who want to hold office should be able to pass a basic science test? Look, I get where you're coming from, but I'm not in favor of any kind of tests in order to let people participate in, public service. That's to vote, that's to serve. What you're really asking is we'd like people to know what they're talking about when they're making decisions about public policy, but of course they could also have experts available and they could ask them and they could learn. So, yeah, I get the sense. Yes, I wish all of the people running the government were better perhaps at understanding the science of this pandemic before they made policy or decisions, but I still wouldn't go so far as a test. Some Western states with a lot of land and low populations seem to have way fewer cases and deaths. Are rural areas at lower risk? In some ways, yes. In some ways, no. The yes ways might be much easier to socially distance. It's very possible that in certain parts of the country there aren't a lot of cases, and therefore you're at very low risk of getting it if you go out. The problem is that our capacity to test and trace and manage and even have hospital systems out there should you get very sick is lower. So some things are better, but some things are potentially worse. So I don't know if it's more recommended or less recommended overall. I keep hearing a lot about error rates for COVID-19 tests. Is it any worse than the typical error rates of other tests? Well, some yes and some no, and it depends on which test you're picking. You should go back and watch all of our episodes on sensitivity and specificity and test characteristics to understand what's going on. The biggest problem is that some of these tests have pretty high rates of false positives. That's not a bad thing necessarily if there's a lot of disease in your area, but if there's very little disease in your area and there's a decent chance of a false positive, then almost every single positive will be a false positive. So the problem is a lot of these tests are all over the map. The other problem is that the regulations for some of these tests are not as high as we would normally do because we're trying to rush them out there. And so some, especially antibody tests, seem to be pretty bad. And we don't know exactly how good they are, and people are getting them, and what do you do with the information? They're offering antibody tests in my community. Is it safe to assume these are reliable tests when the majority are not FDA approved? You should listen to the answer to the last question. I don't necessarily think I would be running out and just getting an antibody test because your doctor's office has one. There's a lot of tests out there that still have pretty sketchy test characteristics, and until we have a better sense of which ones are good and which ones are bad, and you know exactly which one you're getting, it's still a toss-up for a lot of these. And for the people with antibodies, what are your thoughts on giving immunity certificates to them? I am personally very uncomfortable with creating tiers of society based on disease things. That almost always ends badly. So, one, it's going to set up some dynamics in society where some people are allowed to do stuff and some people aren't. It's also going to create incentives where in order to work or go out, people need to get infected, and people who need to go out and work or do stuff might be inclined to try to go get sick. That's not a good idea. So for all these reasons and more, I'm not too keen on that. Having said that, there are some instances, perhaps in providing healthcare, where it might make a little more sense to know if somebody has already been exposed and is immune, might be a little bit better off taking care of people who actually have the disease. So I can understand some arguments and workarounds for it, but in general, creating classes of a society based on whether or not you have certain health conditions, again, doesn't usually turn out well. What is to be made of recent serological antibody studies like the one published in Nature from Santa Clara, California, that have estimated the prevalence of the disease to be up to 10 to 50 times more than the official reported case numbers? Doesn't that make the fatality rate much lower and thus the current lockdown too extreme? There are problems with that study, and you should go read Carl Bergstrom or others about that. It was not totally random. It's also it's a smaller study, and to extrapolate it, first of all, even to California is a big stretch, but then to extrapolate it to the country is a huge stretch. There are other studies in other areas that don't show the prevalence to be that big. Right now in Indiana, we're actually conducting a pretty random statewide survey, which will give a different statewide prevalence. And a couple things with that. One, yes, the more people that have this and we don't know reduces the fatality rate, but still the hospital systems get overwhelmed, as they did in New York, as they are in Italy and in Spain. And so to say, oh, well, it's less, we could just open up and it was too extreme. We did the extreme sheltering in place to avoid overwhelming the healthcare system and flatten the curve. That's why we did it. not because of the high case fatality rate. So to say this was too extreme is to say that we were doing it not to prevent it. That's not why we did it. And so if the case fatality rate is lower, great. That means we might get to herd immunity a little bit faster, or more people might be immune, but it does not stop the fact that we could have easily overwhelmed healthcare systems in many other parts of the country if we didn't do the social distancing that we did. Scientists like John Ioannidis have stated that contact tracing is futile given the unexpectedly large numbers of verified infection in Santa Clara, LA County serological surveys. What do you think? Again, I would encourage you to go back and listen to the last question. We don't know necessarily how many people actually have this in general. That's a survey of, first of all, just one area of the country. There are a lot of countries that are doing contact tracing and isolation and succeeding massively, South Korea being the best example. But there are other countries that are doing it as well. So to say that those countries are doing it wrong makes no sense. Good contact tracing and isolation is the mainstay of trying to stay ahead of this. Now, if it turns out that nationally, yes, everyone's got this and we can't track them, then yes. But again, just because we have one study in Santa Clara that tells us that they think the prevalence is that's not what every part of the country is seeing. And it may be that it is not what they think it is. There are issues with that study. And so it would be somewhat premature, I think, to start changing international policy on how to deal with pandemics for a long time. It's not new policy. This is how we deal with pandemics, to try to change that on the fly with imperfect evidence. And so, no, I'd still argue that contact tracing and isolation is the way that you prevent outbreaks from happening. What's the deal with GI symptoms? Should I be self-isolating if I had GI symptoms such as diarrhea? I wish I had good answers for you on that. I mean, look, we should be self-isolating no matter what, because at the moment, almost everybody is in a shelter-in-place rule. With any kind of symptoms, in an ideal world, you would go out and get tested, find out if you've got this, and then know whether you should be quarantining or not. We don't have that world yet. Testing is not as prevalently available as we would like. But that's the future, and that's where we would go, where if you had symptoms of any kind that you were concerned about, you would get it. And that's really in the criteria to come out of this, which was last week's episode. We should be able to test everyone who is symptomatic anywhere, and this would include that. Can you go into detail about some of the non-respiratory complications of COVID-19? I've seen or read that some patients are at high risk for blood clotting issues, kidney failure, cardiomyopathy, etc. Yes, all of those things are true. We don't have good numbers, unfortunately, on how common they all are, but the bottom line is that this is an infectious disease. The way to avoid everything is prevention. Prevention. It's not like if you do anything else, you'll be at less risk for one of these things than another. So to some extent, I wouldn't focus too much on them and their details. There's lots of bad outcomes from this, including hospitalization, including ventilation, including death, including all the same things you did, which is why we need to focus on prevention and make sure as few people as possible get this. Any advice on combating all the misinformation out there? I see it everywhere on social media, and half my family believes quacks in the internet over me. The best thing we can do is not promote or focus on any of them directly, but continue to, I think, positively put out good information. The more attention and light you give bad information, the more people pay attention to that. I think we've covered that in previous episodes. It's happened before with anti-vaccination efforts and everything else. The more we legitimize those, the more power they seem to have in some people's mind that that's a legitimate stance to take. What we really need to do is just keep promoting good information. Some people want to believe bad stuff and are therefore going to look for excuses to support that. So whatever, you're not going to fix that. But again, promotion of good information. Speaking of misinformation, some people are having a fit because a 2018 show on Netflix was talking about coronavirus. Can you explain the difference between the words coronavirus, COVID-19, SARS-CoV-2, etc.? Coronaviruses have existed for some time. There have been some which have been causing colds. 4 of them, I think, maybe 5, I can't remember, but have been sort of in the human population and come and go, but really don't ever go away. Of course, SARS in 2002 or 3 was a coronavirus, as was MERS. In fact, one of the reasons we're calling this SARS-CoV-2 is because it is another severe acute respiratory distress disease caused by a coronavirus. It's the second. COVID-19 is the syndrome, I believe that's what we're calling it, but they're all coronaviruses. Many of the outbreaks or new concerning potential pandemics of the last 20 years have been coronaviruses. So yeah, don't freak out because you've heard about them in 2018. A fair amount of claims out there that ingesting the virus is less likely to infect you. Seems weird since it's still getting in your mouth. Thoughts? I mean, I think people are mostly concerned that this is getting into the lungs. So clearly, if you breathe it in deep and it gets deep into your lungs, that's a concern. Remember that while your trachea and your esophagus both come out of here, they are separate. So if the virus just goes down your throat into your stomach, I suppose then, there's a higher chance that your stomach acid will kill it or that something else will happen and you're less likely to get it. But we're not doing like randomized controlled trials of this, and we don't know. And the bigger problem is that, you get it on your hands, you get it in your mouth, eventually you might inhale some of it or aspirate, or it gets in your body and somehow gets in your lungs, and that's all bad. So avoid getting it any way you can. Hand wash, hand wash, hand wash, hand wash, hand wash. Don't touch your face. Hand wash before you eat. Stay away. Don't cough on other people. Don't be around other people when they're sick, and wash your hands. That way it won't ever get near or in your mouth, and that way you won't get it. Can the virus spread by means such as office air conditioning units? Yeah, we don't know. There was that study out of China that sort of modeled how one sick person in a restaurant infected like 9 other people, and they think that some of it was through air conditioning, which is horrifying. But we don't know. We don't know if she was coughing. We don't know what was happening. So this is one of the things we will have to monitor as we go. But, it's less likely. Again, it'd have to be through aerosolized droplets, which somehow get sucked up in the air conditioning and brought around, then it'll never settle or die. So that seems less likely. Plus, if this was truly just spreading like that through buildings, then you'd expect that no one would be safe in a large building. And clearly, that's not happening. So we'll have to wait and see. As a low-risk individual, am I more useful socially isolating or working and donating the money to people who are at high risk so they don't have to go out themselves? It's a tough question. So, at the moment, we're all socially isolating because we don't know who has it and who doesn't. And because this is how we break the exponential growth and get things more under control. I expect that as we open society a bit and as we move into other phases, that still rules and expectations will likely be different for people at low risk versus people at high risk until things are really safe. So I think you'll see that most of the recommendations, even as they call for easing and restrictions and thinking about going back to work, will likely apply more to people at low risk than people at high risk to begin with. And that eventually, hopefully, we ease up so people at high risk can go out. But at the moment, everyone, for the most part, in most states, is still all sheltering in place. Much of the country has been sheltering in place for several weeks now. Why are we not seeing more progress? Are we doing a bad job of socially distancing, or do we just need more time to see results? I think we are seeing progress. I think that there are lots of places in the country that have seen us crest and hopefully start coming down. That's what progress looks like. If you expected fast results, I'm sorry. In fact, my last column, 2 columns ago at the New York Times, was talking about that we think this is going to be this easy, fast, symmetric curve, and it is not. Most of the countries in Europe are like trailing, and so that's probably what we'll see. But most places have avoided the crush that New York did. That's what success looks like. Most have not seen the level of outbreak that some places have seen. That's what success looks like. Some states have not yet hit their peak, or cities have not seen their peak and start to come down. They probably still need to continue to do this and wait. So there has been progress. Unfortunately, it's slow and it is hard to feel good because progress isn't like disease gone. Progress is many fewer people got the disease than we might have gotten. Many fewer people died than we might have had die, and that's hard to see. It seems we're in a marathon and not a sprint. While shelter-in-place orders are effective, they do not seem sustainable over the next year to 18 months, and that it will take to develop a vaccine, while less effective but more sustainable strategies are being discussed. I think we've talked about that before, and I've certainly written about it, but no one is saying, or very few people, almost no one is saying shelter-in-place 18 months. It's get it to manageable levels. Build up contact tracing and isolation and massive levels of testing so that we can open up and that we can track down still all the cases that are showing up and then isolate them and quarantine those we have to, and continuing to track down everyone they were in contact with so we get this to a manageable level and then we hold the line. That's what South Korea is doing, Taiwan, Australia, New Zealand. That's the game plan. But we have to suppress this enough to get to a manageable level of a low enough number of new cases a day that we can accurately identify them and contact trace and isolate them so that we don't have another outbreak. So that will take time. So we got to keep this going down long enough that we can build up this infrastructure to continue to keep a level on it so that it doesn't come up against it. That is the goal, not stay in place for 18 months. In the absence of a vaccine, is acquired herd immunity the only end game of this? And if so, shouldn't we allow more exposure outside of high risk groups? Slowly is the problem. Because if you just expose than chaos and overwhelming of the healthcare system and massive levels of death. Even if it's a small percentage that die, I mean, let's say it's 0.01 or 0.1. I mean, 0.1's the math is a little easier. If we let 50% of the population get this, that's 150 plus million people. Even if it's 0.1%, that's like 150 becomes 15 million, becomes 1. That's still 150. Like, it's still a lot of death. We don't want that. So, letting this rage is not great. So we're trying to get as few people infected as possible until we can get a vaccine. We can go back to more normal life once we've reached herd immunity, but you can exist without getting herd immunity. Again, South Korea, Taiwan, up until recently Singapore, New Zealand, Australia, Hong Kong. Like, you can get back to a more normal way of life. That's our goal. And then hold the line until we get a vaccine. What countries have had the most effective approaches to this pandemic? Same list, until recently. I mean, Singapore been doing a good job till their outbreak, and still they're on top of it pretty well. Taiwan, Hong Kong, South Korea, Australia, New Zealand. I mean, there are success stories around the world of countries that have managed this from the beginning, kept it low, and have really pushed it down to very low levels and staying on top of it. That will take a sustained approach. The rest of us are playing catch up. We've had massive outbreaks. We need to suppress them down and then try to play the same game. What do you think about Sweden's very relaxed approach to the pandemic? So it's being referred to that way. It's just not as mandated as it is voluntary. They're still doing a lot of social distancing. They're still, movie theaters are closed. It's not like they're just go wild. It's just trying to get them to be more in this together. And it's not yet, we don't yet know how well that's working. Their death rate is way higher than Norway's, even though it's like 10 times as high as Norway's. Let me put it this way, they've had 10 times the deaths of Norway, even though Norway is only half as big. So other countries are managing this, it appears, a little bit better than Sweden is, that are close to them and very like them. So we're not sure yet how well this approach is going to work. And it's very possible that if what they're doing of, asking people to volunteer to socially distance doesn't work, that they're going to have to mandate it anyway. So there's just a lot of differences, and it's not clear yet. But it is not like, oh, spring break in Sweden, go crazy. It's not what's happening. What do you think is the biggest misconception about this pandemic? So many big ones, I should say. The one I just wrote about most recently was, I think that people are being presented with this false choice of, we can either save the economy or we can save people. No. Economists agree the way to save the economy is to save all the people, because until people feel safe, they ain't going out. They're not going to be employees. They're not going to be customers. And the economy will still die without those two groups. So the only way to make sure we have plenty of customers and plenty of employees, which is what you need for a functioning economy, is to make people feel safe. The only way you do that is by doing the thing public health experts are trying to do. So everybody's on the same page. It's not a false choice. The disconnect is sometimes between policymakers and everybody else who's telling them what to do. But I think economists and public health people are much more on the same page than a lot of the news would have you believe. Hey, if you found this episode useful, you might find these other episodes useful, where we also answer your questions about COVID-19. And if you can, like and subscribe down below, really helps. And also support the show in any way you can through patreon.com/healthcaretriage. It's harder than normal to keep this going in the pandemic. And again, as much as you can, we really appreciate your support. It helps us to keep this coming out. We'd like to especially thank our research associates, Joe Sevitz, James Glasgow, and Joshua Gister, and of course, our Surgeon Admiral Sam.